Hello, everyone, and welcome to our next installment of Dr. Gilbert Hosts. My name is Dr. Rebecca Gilbert, and I am the Chief Scientific Officer at American Parkinson Disease Association, or APDA for short. Thank you so much for joining us today. We will be discussing advances in deep brain stimulation, or DBS. American Parkinson Disease Association is the largest grassroots network dedicated to fighting Parkinson's disease, and we work tirelessly to assist the more than 1 million Americans living with this disease and hope those people can live life to the fullest in the face of this chronic neurologic disease. Please visit our website at apdaparkinsons.org to explore all that we have to offer. And this includes programs and services delivered by our network of chapters and information and referral centers across the United States. Our website also hosts a vast array of articles, webinars, presentations, and information that can help you understand your Parkinson's disease. You can also contact APDA via our toll-free helpline at 1-800-223-2732 and via all the social media outlets. I'd like to thank Genentech and Medtronic for sponsoring this series, and I want to acknowledge their appreciation for the critical need to provide programs like this to help people like you with Parkinson's disease. And now for today's program. Today, we will be discussing deep brain stimulation for Parkinson's disease, and we will focus on the new developments in Parkinson's disease deep brain stimulation that have come to market over the past few years. And we will go over these various options in a brief introduction, and then we'll jump straight into your questions, which you have either submitted already during registration or that you will submit now during our presentation. My guest today is Dr. Alon Mogilner, who is a neurosurgeon at NYU Langone Medical Center and the director of the Center for Neuromodulation at NYU Langone Medical Center. He is an associate professor of neurosurgery and anesthesiology at NYU Grossman School of Medicine. He specializes in the surgical treatment of Parkinson's disease and other movement disorders using deep brain stimulation and other technologies. And Dr. Mogilner is a graduate of Columbia University and the combined MD-PhD program at NYU. He then underwent neurosurgical training at NYU with specialty fellowship training in the surgical treatment of movement disorders. The NYU Center for Neuromodulation treats hundreds of patients per year with Parkinson's disease and other movement disorders, utilizing the latest surgical techniques via a multidisciplinary approach in conjunction with a team of movement disorder neurologists. He's involved in multiple clinical trials in the use of DBS and other technologies to improve the lives of Parkinson's patients. Dr. Mogilner, thank you so much for joining us today.
Thank you so much, Dr. Gilbert, and it's a pleasure to be here today and to talk with you about some exciting advances in deep brain stimulation. And I would imagine that many of you have heard about deep brain stimulation, or DBS. For those of you who haven't, a brief introduction. It is a surgically implanted device that is placed in the brain and connected to a device placed under your skin, usually in the region of the chest. So, for example, you see here a lead. The lead is called the electrode that's placed into the brain. That has what's called 4 contacts in this example. It then is tunneled under the skin, and then an incision is made in the chest where a device is placed under the skin called the generator, which is very similar technologically to a cardiac pacemaker. So this, again, is a surgical procedure. It is done at a number of centers with expertise. The surgery itself we can discuss if there are any specific questions about how long it takes and so on later. But this procedure is not new, it is not experimental. It has actually been approved for approximately 20 years in the United States, a little bit longer, and it has gone from something that was a little bit, as we mentioned, initially experimental, a little bit niche, to something that is well established, that it is able to help the lives of many people with Parkinson's disease. So specifically today, what we're going to talk about are new advances in DBS. So for example, if I were giving this same talk about 5 years ago, most of the talk wouldn't be here. So the DBS world was more or less stable until about, let's say, 5 or 6 years ago. There was one device that could be implanted. It was the same device that had been used for years. And despite that, it worked very well. But now there are more than one device. And in fact, the devices themselves can do additional things that they were unable to do before and actually provide better outcomes. So now there are 3 different companies that actually manufacture the equipment for DBS. In terms of chronological order, and when they were introduced in the United States, Medtronic, followed by Abbott, followed by Boston Scientific. And in 2016, the FDA approved DBS for earlier stage Parkinson's. What that means is, initially, the approvals were for people who had had it for what's called longer or advanced Parkinson's disease. And in fact, there was no specific timeline in terms of X years, 8, 9, 10, 11 years. But what was shown was that in patients who had it for shorter periods of time, do just as well, if not better. So the FDA specifically said this is not something that you need to wait for 10 years or longer to do the surgery. In fact, it may very well be that the earlier the better. Additionally, in the past, people who had the implants couldn't get MRIs. That is no longer true. All the devices now are MRI conditional, meaning MRI conditional, the word conditional really means approved. In other words, nothing is 100% guaranteed, but MRI conditional means the FDA approves it. So if you need an MRI of any other part of your body, you can get an MRI. Furthermore, the pacemaker or generator, there are different types of them. 2 of the companies have what's called a rechargeable device. It means it lasts longer. So the older devices lasted, depending on the individual, from 3 to 5 years, and you would need another surgery to replace them, not on the brain, but on the chest. Now there are devices that may last 10 to 15 years or even longer. Rechargeable devices, and in order to keep them going, about once a week, patients will have to wear a little harness for about 30 minutes, sort of like recharging your phone through a wireless recharger. In addition, in the past, people may be familiar with patients who had one generator on either side of the chest, one for the left, one for the right. Now each company makes a dual channel device that you only need one device to control both electrodes. And finally, on this slide, we can do what's called a sleep DBS. In other words, we can actually get a scan of the brain in the operating room, which helps us be even more certain that we place the electrodes in the correct location. The way we've done it for many years was a very good way of doing it, but we actually have even more certainty now that we are placing the electrodes in the correct location in the brain to help the patient get the best outcome, and therefore people who do not want to be awake for the procedure do not need to be. We can also discuss that later. Why would you choose to be awake or asleep? What's better or not? Now, the next video I'm going to show, perhaps many of you have seen videos of people with tremor, and you turn the device on and the tremor goes away. Those are the easiest videos to show because it's actually very straightforward. The tremor is there, it's no longer there. But what I'd like to focus on today is really the fact that DBS helps a lot of other symptoms, because many of you may be aware that not everyone with Parkinson's has tremor. And in fact, about 25 to 30% of people never have tremor but have severe other symptoms of Parkinson's disease, the difficulty with their walking, the stiffness, and the slowness. And there have been some misconceptions in the past where people ask, I don't have tremor, why should I get DBS? And the answer is because it helps the other symptoms. So we'll show the video of an individual before and after surgery, a rather young man, is walking before and after surgery.
Okay, I'm going to try to take a few steps.
Obviously the gait is very shuffly.
That's pretty much it. Okay. That's fine.
Shuffle along, yeah.
Yeah, we can go.
We're going to walk backwards. It's really weird.
It's better when you walk backwards.
If I walk backwards like this,
Uh-huh. that seems better.
I can walk back but not forward.
That's interesting.
I go stairs and downstairs, no
So
problem.
you want to turn around and walk back to the chair?
Let's make it feel, yeah.
That seems better.
Yeah, go up and downstairs, no problem. It's just flat forward, no problem.
That's good.
Turn around. Go one more time for me. Okay.
So just to go over that, interestingly, so that's a young man who had what's called bilateral DBS performed, and this is now about 2 to 3 months out. Just to let you know, he's now off all of his Cinemet, which doesn't happen for everyone. So that is again the difference between it's not medication. That's not a medication side effect or effect of the walking, because obviously you may say, well, maybe he took his medications. He has been able to remove all of his Cinemet, and that's just the stimulation. You see the dramatic difference. So now in terms of new developments, so a couple of things, we'll have a couple of slides for each different company. So Boston Scientific has introduced what's called MICC, or multiple independent current control. And just briefly from an electronic standpoint, the electrodes have 4 to 8 different points in the brain, and you can turn on and off each one. And the advantage of this particular system is that you can turn each one on and off, but you have what's called a dimmer switch. So for example, you can give 20% to one, 30% to the other, and it's a lot of fancy computer science, so to speak, but you may find that, for example, one contact is better for the tremor, and one is better for the walking. So you can actually have on each individual one a resistor, so to speak, and you can give different percentages. The other companies don't have that, and we have found that in some people it actually makes a significant difference in terms of the best symptom relief and modifying it and improving each symptom in a symptom-specific way. And they also have, we'll talk about this, 2 companies have something called a directional lead. So what that means is, imagine if you drop a pebble into a pond and you see the circular waves coming out. That was the way DBS was done until about 5 years ago. So when you stimulate the brain, the stimulation would go everywhere. It would go to good places and sometimes to bad places. What do I mean by that? That means that sometimes if the electricity would go to somewhere that it shouldn't go, you may feel some tingling or your muscles may tense, and sometimes it would be very difficult to get around that. So now you have what's called directional leads, that you can send the stimulation front, back, left, or right. 2 companies have that, and that is a big advance in DBS. So you can actually not only improve the symptom relief, you can improve the side effects, and in fact, although it doesn't make sense electronically, you can actually have longer battery life because you're using specific segments of the device. You see here, for example, that the current is only going to the left and not to the right. Abbott as well has, in addition to the directional lead, they have, for you techies out there, they have actual iOS capabilities. So this is the only company, which is amazing. You can now control your DBS on your iPhone. So what that means is, and we'll talk about that later if you'd like, when the surgery is done, the doctors, usually the neurologist, will set the device up at their first visit and see what the best settings are and send you home and say, okay, you can increase or decrease by doing so and so on your patient controller. And the other companies have what's called a specialized device. Abbott actually allows you to use your own iPhone. So just as an example, if you have the surgery done and you go home and come back to the office, and the first week it seems to work on your tremors, and then 1 month later your tremors get a little worse, you can actually take your iPhone, increase the stimulator, and make your tremors better. This is a significant advance in the ease of use of the devices, and that's the only The Abbott is the only system that has that. The other companies also allow you to change programs. All of them allow you to change programs. The Abbott actually has what's called the iOS method. And in terms of Medtronic, this is the other company, which again was the original company, and now has just come out with a unique device that, called the Percept. So when you think about stimulation, if some of you are familiar with heart pacemakers, you may know that heart pacemakers for many years, or defibrillators for that matter, they listen to the signals from the heart, and based on that, they decide how much stimulation to give. Right now, the DBS systems have never been able to listen to your brain. They only stimulate. So the doctor will decide, in conjunction with you, what are the best settings. In the future, it is very likely that the DBS systems may be able to work even better by listening, to use the same electrode and to say, okay, what's going on in your brain now, and how does it affect you, and perhaps that will tell us. So right now, the Percept, which is FDA approved, can record something called LFPs, that means local field potentials, and basically that means it can listen to your activity of the brain in the part of the brain called the STN or GPI, and it can do a map or a record of your symptoms based on the local field potentials, and we can use that information down the road. The doctor can use that to modify the stimulation, and probably in about a year or two, we'll be able to do that automatically. That's called closed loop stimulation. It doesn't exist yet in the US, but the device itself, if you implant it, will be probably unlocked to do that in about a year or so. Now, moving on from DBS, we can't really have a talk about surgery for Parkinson's disease without mentioning a different technology. A lot of people have been asking about that, which is really a great introduction or improvement or addition to our armamentarium. This is called focused ultrasound. This procedure is about 9 years old. In the US, it's been approved for about 4 or 5 years for the tremors of Parkinson's disease, as well as tremors of essential tremor. And the remarkable thing about it is that it's not open surgery. It's a same-day procedure where you go into a specialized MRI machine, and the machine delivers ultrasound waves, and they all add up at a particular point in the brain, and they do an ablation. So an ablation is, quite frankly, it is making a lesion or burning a tiny hole in your brain about 3 millimeters. However, it's done in the right spot in the brain to get rid of the tremor. And as I mentioned, you come in the morning, you leave in the afternoon, and your tremor is gone. Now, so again, to discuss why and when the differences. So, outpatient, can you do it on everyone? No. The bones of your skull have to have a specific composition. We have to do a CAT scan to evaluate it. About 80% of people in the US can get it done, and about 20% of people can't, because the waves can't go to the skull. Also, if you really can't get an MRI, if you have some device in your body that you can't get an MRI, such as a pacemaker that's not MRI compatible, you can't have it done. If you can't cooperate or lie on your back for 2 to 3 hours, also you can't do it. Finally, it is now approved only for one side of the body. The reason it's not approved for both sides is that we have data from many years ago, based on old-fashioned lesioning, in other words, when surgery was done, that when you do it on both sides, it's possible that other symptoms could get worse, such as speech or balance. So right now, it's approved for one side. I have, and others have started to do it on both sides for tremor, although it's unclear in terms of the 100% safety profile. Now, in terms of the results, just to show you some studies, this is a 4-year study of tremor. And again, it is for essential tremor, not Parkinson's. We can discuss the Parkinson's as well in a minute. So higher bar means more tremor. So before the procedure, this was their tremor score. Afterwards, you see it's significantly lower with a little bit of an increase. And in terms of disability, in terms of time, you also see a significant improvement performing the procedure for one side of the body. Now, what about the other symptoms of Parkinson's? I mentioned earlier on that I didn't want to show you a slide of tremor because there are other symptoms. So right now it's under research. In other words, the bradykinesia, the slowness, the stiffness, the rigidity. There are clinical trials which are just finishing up to treat the other symptoms, and we do see improvement in most of these. So if you're familiar with it's called UPDRS. So UPDRS is a score to decide or to quantify how bad your Parkinson's is before, and you see that the higher numbers are worse, and after surgery there is an improvement in the what's called the motor UPDRS off medicine, as well as what's called the dyskinesia rating scale. So if you know, you must, those of you who know what dyskinesias are know what they are. They're the abnormal movements you get from medication. So it does seem that this is a unilateral procedure, and it will probably go to full FDA approval in the next year or so for one side. Remember, one side. Okay, so that's the end of my slides, and I'm happy, and Dr. Gilbert will be delivering the questions. I hope this was informative, and let's move on with the questions.
Excellent. Well, thank you very much for that introduction about DBS and all the advances. It is a very complicated topic. Each one of the companies offer different, very exciting new advances. So the first question that I have been fielding from many different people who submitted questions in advance, etc., is how do you decide between these companies? Now, a corollary question is, and this is something that I get asked a lot, if I am referred to a specific surgeon, and this surgeon has a particular device that they work with, do I accept what the surgeon is telling me and go with that device? Do I look around for other surgeons who may have expertise in different devices? How is one person who never went to medical school able to navigate this? What is your advice on that very complicated question?
Great question. I'll answer the second question first. If a surgeon really says I only work with one device, I would question them. In other words, you have to understand why. I work in most places, implant all the devices, and again, as you know, you may have a preference. Each surgeon may have a preference for specific reasons, which he or she can tell you. From my standpoint, when I think about it, some people do their research and they say, listen, I've researched and I want device to be put in. And unless I see a real reason not to, I have no problem with that. So when a patient comes, again, it really depends on an individual case-by-case basis. The first question I will ask them is, or I will assess them and say, would you want the rechargeable device or the non-rechargeable device? Now, why do I ask that? Because right now, one company only has a non-rechargeable. So if someone says, listen, I want a rechargeable device, then we have already ruled out one company. Then we go on, and then we say, okay, what are the other issues, and so on. What are the symptoms? There are people who say, hey, I like the iOS, I want it on my iPhone, so that also leads you to a company, and so on. And then people are very interested in this last thing, the sensing device by Medtronic, and as I say, that's fine with me as well. So overall, as I mentioned before, there are some advances that only a number of the companies have. Directional leads right now are only available in 2 or 3 companies, and people are well educated. People may come and ask that. So overall, we get a general feeling. And it turns out that I and my colleagues in neurology, we may assess something. Listen, something, I think a rechargeable is not good for you, or so on. And even if the patient says it is. So overall, I think it is a case-by-case basis. And I'll emphasize the second answer. If someone says, I only use company X or Y, you have to question exactly why. If they can convince you and so on, okay, but that doesn't really make sense to me. We use all the companies and so on. I think you need to really, you have to trust. One of the things, again, it's, as you said, if you didn't get the degrees, you do have to develop sense of trust with the neurosurgeon and the neurology team to trust that they're doing it in the best interest of what we think is right for you. And I've had patients change their mind. What I ask patients is, listen, also, do your reading. I think these both are good for you. All I ask you is let me know like a day or two before, you know what I mean, just so I know which like reps and so on. But some people say they'll think about it and they get back to me, and that's completely fine. But it is our job to put out the choices there and explain, you know, what, and they will say, what will you do? What would you do if it were you or your family member? And then I'll actually say, I would do this, or I would flip a coin or something like that.
Excellent. Okay, great. I have another question that's come up a few times from our audience, which is, I have a DBS already in place. Can I take advantage of any of these new technologies without undergoing another major surgery? Is there any way that my device can be adjusted in any way to help me more than my current DBS?
So the answer is yes. So there are the lead in your brain you don't want to replace. You know, if it's working, that's the one thing you don't want to have to go back into the brain to do. So I would not recommend that. On the other hand, the generators now, you can take a newer generator and attach it to an older lead, with, you know, with some limitations depending on the company, and use some of the new features such as sensing or MICC, multiple dependent current control. So it is possible, and we've had patients like that where we've actually been able to improve symptoms by taking out an older generator, putting in a new one. And there is some data now that suggests, for example, some issues with speech. And again, this is very new. I'm not going to promise it, but issues in terms of speech may be better, and with different what's called pulse width and so on. So the answer is possibly, possibly.
Okay, great. Another question that comes up very frequently is DBS and cognition. So two types of questions are asked. Does DBS help cognition? And then other people ask, does DBS hurt cognition? So if you could address the general topic of DBS and cognition, that would help our audience.
Happy to. So does DBS help cognition? So the areas of the brain that stimulate do not inherently improve memory and thought processes as far as anyone can tell. Now, can someone's overall cognitive status improve following DBS? I can think of scenarios that it can. So for example, if someone's on a tremendous amount of medications for Parkinson's that can interfere with their overall, you know, even if they needed to keep them mobile, but can cloud their mind and cause side effects and so on, if DBS allows you to lower the medicines, then as a what's called an indirect effect, you should make it better. So for example, so that could happen. So it is possible. But DBS in and of itself will not stimulate the cognitive parts of the brain to make you think better, so to speak. Although putting in a DBS, we have definitely had patients who said, you know, I've lowered my medicines, I feel much clearer and sharper because I could lower my medicines and I don't need them anymore. Next question, can it make the cognition worse? So the answer is it depends what your cognition is like before. If, God forbid, some horrible event occurs, extremely unlikely, you have a hemorrhage in the brain, of course it could make it worse. That is so uncommon that, you know, we have to mention it, but the chance of that happening is probably, you know, less than 10%. But on the other hand, let's say the surgery goes completely, perfectly with no complications. We do find that if someone has a pre-existing cognitive deficit, there is a possibility that it could get worse, and that's why every patient that we operate on has a formal neuropsychological test, which means you go to a psychologist, do a 2 to 3 hour test, and we assess every aspect of your cognition, executive function, and so on. If someone has significant dementia, we won't do the surgery because there is evidence that it will get worse. But if someone has some mild issues with memory, we will assess that, and if we do think that there is an increased risk, we will let you know. So again, having done this for over 20 years, we have a general idea of who would be at risk and who would not, and we would stay away, would not recommend it. Now, when I say that, that would mean the following. You can have someone who with DBS would work amazingly for the tremor, the bradykinesia, and the dyskinesias. They may look great, but then the family would say, well, yeah, but their memory got worse, and I don't think we should have had it. That's what we want to prevent, obviously. First, we first want to do no harm, and it means that we don't want to get something better, but something worse, and then in the big scheme of things, you feel that the bad outweighed the good.
Okay, great. Thank you for that. Another question that gets asked very frequently is age and DBS. Is there an upper age limit that you have for your practice or generally? And people are very interested in knowing how old is too old.
Okay, good. All great questions. So, as we all know, a number doesn't really have much meaning, but. So, they say 80 is the new 60, and so on. But when someone is approaching 80 years old, we get nervous, so to speak. What that means is the risks of any type of surgery go up. For, let's say, the standard Parkinson surgery, targeting both STN and so on, as someone is in their late 70s, we are definitely more prudent in terms of risk-benefit analysis. I would probably pick the early 80s as a cutoff that I would stop at. The oldest, let's say, bilateral STN location patient I've done is about 82. However, people who have just tremor, or essential tremor, for example, we are doing it on a little bit older patients. And ultrasound, just to bring it into another aspect, has no age limit. I've done ultrasound on patients 95 years old. So DBS, if I had to give a number, right when you're approaching 80, be very, that's when the doctors sort of get, worried about it. But again, you can have a 60-year-old who has so many medical problems that you don't want to operate on either.
Right, got it. So it sounds like the high intensity ultrasound is another new option that can help you expand the number of patients you can help if it can be used for the older population. So let's use that as a segue, which is another question that we get asked a tremendous amount. If your neurosurgeon presents to you the two options, deep brain stimulation, high intensity focused ultrasound, how do you make the decision which way to go?
So let's talk about the current state. Obviously, we're talking about the current statement. So right now, it's FDA approved to treat the tremor of Parkinson's and nothing else. We don't know yet the effects on the rigidity, bradykinesia, dyskinesias, and so on. A. B. It's only approved on one side. Now, so those are the things that you have to think about. So if someone comes into the office and wants the ultrasound, but has symptoms on both sides and is dyskinesia and so on, I'm not going to offer it to them even if they want it. In other words, and I've had patients that come in, they have tremor, and it bothers them, but in reality, that's not their big problem. And they have bilateral symptoms, rigidity, dyskinesia, and it's not fair to just do something. It's a very safe procedure, but I won't recommend it unless currently we believe that treating tremor on one side of the body will make a big difference in your quality of life. And now, this will probably change in the next year, where we'll talk about treating the other symptoms, but again on one side of the body. And maybe in 3 years, let's say, we'd have enough data to suggest it on both sides. So finally, someone may be a good ultrasound, but we do the CAT scan, and what's called their skull density ratio is too low. And we've had a lot of patients that love the idea of the ultrasound, and I'd be happy to do it. And the CAT scan says, listen, we'd love to do it, but we can't, and we'll do DBS. And sometimes you have patients that we've tried the ultrasound on. I've had one patient like that, and it worked for about 3 months, ended up having DBS. Or we had a patient that we thought it would work, and the density was fine, but another parameter called the thickness was too much, and we basically couldn't do it. So a month later, we did DBS, and he's very happy. So again, what I'll stress in that regard, and again, the way it is in the country now, ultrasound is not available. You should really, if you're going to go to a place that doesn't do it, there's going to be a bias. They're going to say, don't do it, but if you would see them the next year when they get it, they probably want to do it. So you have to be careful about that. I'm very lucky, NYU is one of the 15 or so places that have it. We have what's called equipoise. It really doesn't matter to us what we do for you, as long as it's the right thing. So you should really make sure that there's not a bias one way or the other.
Got it. Okay, that's very important to know. Thank you. We're getting questions about the sort of combination of ultrasound and DBS. Someone asked, can focused ultrasound be done in someone who has had DBS? And presumably the reverse question is on people's minds as well.
If you have a DBS, and the issue with that is as follows. Once the DBS is in your body, okay, 2 of the 3 companies only allow MRIs, it's called 1.5 Tesla, which is the older MRI machines. Most new MRIs are called 3 Tesla. So since I'm doing it in an MRI machine, if your DBS is MRI compatible with the MRI machine, you can have it done. However, most of the new ultrasound devices are 3 Tesla, and only one of those systems now is 3 Tesla compatible, and it's never been done yet. So there are some ultrasound systems that were installed 4 or 5 or 6 years ago that are called 1.5, and theoretically you could do it on the other side, although I'm not even sure if it's been done. The other way around is very simple. If you have the ultrasound done on one side, there's nothing in your body, so you can definitely have the DBS done on the other side.
Got it. Okay, great. So a bunch of questions coming in about the rechargeable battery. You mentioned that somebody might want the rechargeable battery, and you might say, well, let's reconsider. What would be, I think we can all figure out what the advantages are of a rechargeable battery. What would be some disadvantages of a rechargeable battery?
So I just saw a patient yesterday who says they like to travel in the Amazon jungle, hopefully after COVID, which actually it'll be safer there. But anyway, and they go to places where they have no access to electricity. So I would be concerned about what happens if their recharger, right? Like we all know, the recharger has to be charged and plugged in. So I would be nervous about someone like that. Number one. Number 2, someone who has no caregivers around, and I have concerns that you may need a little bit of help as the years go by with rechargeability. Someone who's not that tech savvy as well. So those are the issues in terms of rechargeability. And then there's another thing, which is really the personality. There are people who say, listen, I don't want to think about Parkinson's every week. I just want to think about it, now and in 3 years when I come in for 4 hours to get the battery changed. And you try to, being a person involved, a doctor involved in this is part surgery, part neurology, and part psychology. There are people who say, listen, I don't want to think about it now. But there's the only counterpart to that is you have to remember, no matter what you have, that you have a device, and you have to see a doctor every 3-6 months, because you have to remember that we don't want to wait till the device stops working and then your tremors come back and you feel really uncomfortable. So we had some COVID issues, just as an example, where people canceled their appointments, and then they called us up and they said, yeah, I forgot. And we had emergencies where the batteries stopped working because we were going to tell them we assess it every 3 months. Now it's getting better because you yourself have a device, you can check it, but the patients just didn't do it at all. In other words, they knew they could check it, and it'll give you a warning, like let the doctor know that you need to replace it in 4 months. So that's the other side of it. So a non-rechargeable, if you see a doctor regularly, great, easy. If you don't, then if you're not aware of it. But if a rechargeable device, that won't happen for 10 to 15 years.
Got it. So many things to think about. Another question that people are interested in, which are sort of a choice to make, is awake versus asleep. So I think people have input questions which imply that asleep sounds really good. What are the disadvantages of going the asleep route?
So to answer the question, sorry to confuse you. There are people that talk awake versus sleep. It's not that straightforward. So for example, we offer both, but even when you're awake, you're not really awake for the whole thing. So why not do it asleep? Let's work backwards. Why should everyone have it asleep, right? If you can be asleep for it, why at all? The answer is because in a proportion of patients, whereas doing it awake will make sure you're correct, let's just say 98% of the time. Doing it asleep will be 92% of the time. So again, still good, but I think in particular symptomatology, for example, people with very severe tremor, it may be that doing it awake gives you a little bit extra advantage as to making sure you're getting the best outcome from your stimulator. Also, just to let you know, there's two types of sleep. There's intraoperative MRI, intraoperative CT. Intraoperative MRI, the surgeries are a lot more anesthesia. They take hours longer, so that's a downside. You really can't test anything. Intraoperative CT, you can test symptoms like side effects and so on. So what we do, my preference is to do what's called awake asleep. In other words, if the surgery is 3 hours, you're awake for about 20 minutes, so to speak, and asleep for the rest, and you don't remember it. But I have had people who've really demanded sleep, and that's fine with me as well. There are pediatric movement disorders, such as dystonia and Tourette's, where I do them all asleep. And if you look at the data now, it's actually very good. In other words, asleep is happening more and more. I'm doing it more and more. I think it's really, you really need to speak to an experienced team. A lot of issues that have occurred, I'm not going to shoot my own or other places, are that there are surgeons who really are not that familiar with DBS, and they'll just do it asleep, and they don't really understand the intricacies of location and stimulation, but since they're uncomfortable doing it awake. So the best surgeons who do the best asleep DBS are probably the same ones who have done the most awake DBS. So it's a good selling point, and before we had the CT scanner, we rarely did it, but there are people who are obviously anxious, severely anxious about being awake, and for those people I think it's a great option, and happy to discuss it. And if someone really says, listen, I would like this, what are your thoughts, happy to do it if it's appropriate.
Okay, great. So a couple of questions about kind of specific circumstances. We have one person writing in that they are prone to developing keloids. Do you have any experience with doing DBS in someone like that?
Absolutely. So people who get keloids don't get them on the head, rarely on the neck. They would get them on the chest region, and they have a keloid scar there, which you can excise. If you know about keloids, though, it doesn't look good, and if you cut it out, it'll come back. So I've had some patients that I've worked with plastic surgeons on that. It's not, so you would have a scar, a keloid scar, let's say over here, which again is not the worst thing, but I've worked with a number of plastic surgeons. You can inject steroids into it and so on, and we've had some very good results treating it. And you may want to consider, in terms of what type of generator, you can make two arguments. The keloid should not interfere with the recharging, and but you could argue that maybe you want to do fewer surgeries and so on. So I have definitely had it, we've dealt with it, and it has not really stood in the way of anyone having DBS because of keloids.
Excellent. Okay, great. So we discussed a little bit about how old is too old for DBS. We have a corollary question, which is, when do you first consider DBS? Should you be considering it early, mid-stage? When do you recommend a neuromodulation consult?
Depends. So the good answer depends. It really depends on your symptoms. So I would say, in a nutshell, here are my rules. Rule 1: if you're tremor predominant, and the Cinemet and all the meds are not really doing that much after 2 or 3 years, go straight for it. Talk about it. Now, why do you even wait 2 or 3 years? Dr. Gilbert can tell you more, but the reason you want to wait at least a while is to make sure you don't have something called atypical. It's not really Parkinson's. It's another condition. But if tremor is your main symptom, and you've gone 2 to 3 years, and you've seen a good neurologist, that's very important, then, and you're not getting any better, and you're on enough meds, go for DBS. Because nothing else is going to help, seriously. Now, what about the fluctuations? That comes to a point of, are you having dyskinesias, and how often are you taking the medicine? So, and most people will have a number of good years where the medicine works really well, but then you get to the point that you get more dyskinesias, and now you're taking it every 4 hours, then every 3 hours, then every 2.5 hours, then every 2 hours. If you're at that point where I would say if you're a fluctuator and you need it every 3 hours, it's a good time to think about DBS. Or if you take the pill and you have unpredictable dyskinesia, some days you're great, but you can't tell, and all of a sudden you get dyskinesia 30 minutes into it, and you're walking down the street and people walk away from you, they think you're crazy or something. So again, just to reiterate, tremor predominant as early as probably about 2 to 3 years already. The other ones a little bit longer, depending on when you get to the point that you're having issues with fluctuations and appropriate medicine. And I will stress that means that you're seeing a good movement disorder center that knows that you've had the right medicine.
Okay, fantastic. That's actually a great segue into our next question, which is, to what extent is a multidisciplinary team necessary for a successful DBS outcome? So we have patients from around the country listening. Some maybe have access to a big medical center and some may not. What are your thoughts on the other people in the team besides the neurosurgeon to make DBS successful?
As Dr. Gilbert knows, having worked with neurologists, I am a strong believer in multidisciplinary approach. Now, why is that? Obviously, a surgeon, the surgeon's job in some ways is just to put the electrodes in the right place. But a neurologist's job is to, number one, make sure the surgeon is doing the surgery on the right people, and number two, to make sure they get the best out of the DBS. And I've seen people who have a DBS implanted by a surgeon, that neurologist, and they've never been programmed, or they should have had it in the first place. I am a strong supporter of a multidisciplinary approach where a neurologist, a neurosurgeon, we also have a psychologist evaluate every patient, works together. Now, that's easy for New York. I understand that, right? So very easy for New York. But what if you live far away? So a couple of things. I will say one of the advances I didn't mention yet, it's so new that they weren't even on the slides, is that one of the companies, APDA, is working on internet programming, which actually means, and I'm not making this up, with the iPad like we spoke about, we're going to be able to do, we were just started to test it. Luckily, we were the first to test it. We can now change the DBS, all the parameters on a video connection. So then that may be better. In other words, you may say, listen, I want to go to the surgeon with the most experience, but there's no one for 500 or 600 miles. But when I get back home, what am I going to do? So that's an option. But overall, it would be said like this. The surgery, you want to go to someone who does this a lot. Now, what does a lot mean? Again, I'm not going to, I'm self-serving to say a lot is 2 or 3 a week because what do we do? But if someone's doing one every month or two, I don't think that's good. You want to have someone who every month is doing a few. If that doesn't exist, it may make sense to go. But if your neurologist himself works with 4 or 5 surgeons and has experience, then you may go somewhere for the surgery, come back to the neurologist. Either way, the multidisciplinary approach, we've had patients come from other neurologists who are very good, and I think they're a good candidate, and my neurology colleagues say, listen, actually, don't do it for other reasons, and you save someone, at the very least, an unindicated operation, and God forbid, a complication. So, again, if there is an issue of distance and getting some places, that can be worked out. And in most places in the country, you're probably a few hours away. But I still would stress: do your research, ask the right questions, and make sure. Just like anything in medicine, you want to make sure that this is what this person does. Does the person do 1 DBS and 10 slip discs and herniated discs in the back, right? You don't want that, even if they're good, because just experience. The more you do, like anything else, I've learned the most from people from my cases that don't go well, right? That you didn't get the effects you want. And if it goes well 90% of the time, that's great. But what do you do about that other percent? So I would strongly support a multidisciplinary approach, and think of the fact that in the future, your doctors don't need to actually be near you, and that may make you more willing to travel to an experience center.
That's fantastic. The ability to program over the internet is just amazing and very welcome in our new COVID times as well. I think we have time for one last question, even though we have so many more that people have asked, but we are going to have to wrap up. So we are going to ask one last question, which comes up again and again, which is, how long do the effects of DBS last? That's what people want to know. Is this something that's going to be a cure? Is this going to be forever? What are your thoughts on that?
So first, okay, I'll start by saying this. I don't know where this came from. There's a misconception. A lot of patients say, well, I heard it lasts for 5 years and it stops working. I have no idea where they got that from. So the answer is, what do you have? So I like to go straight to the point. Let's divide symptoms. For people who have only tremor, I can tell you it lasts as long as I've been practicing. I first, as a resident, did DBS in 1997, so that's 23 years. The data from France is 29 years for STM. So tremor symptoms and rigidity, bradykinesia, I do not see that they stop working. All of a sudden, one day, something stops working. Now, do you need adjustments? Yeah. You may need to turn up the amplitude, perhaps. In terms of the other symptoms, the question really is what happens to your Parkinson's disease, right? DBS at this point is not really a cure, although there is data to suggest that if your tremor is your worst symptom, it does slow the disease. So people ask, does it slow the disease? The answer to that is possibly if tremor is your symptom. If the other symptoms are not, when we turn the device off, your symptoms come back. So again, I personally follow patients 15 to 20 years out with the device is still working. If you get other symptoms that DBS may not help, like as we mentioned, cognitive symptoms, or some people have severe speech issues, or some people have balance issues that nothing helps, no medicine, no surgery, it won't. But the symptoms that it treats at the beginning, it continues to treat indefinitely. And don't let anyone tell you otherwise, because I don't really think they have a good grasp of what patient was sent. And that fake news or misinformation may come from people who were implanted for the wrong reasons and never really helped them in the first place.
All right, that's very important to emphasize. So thank you so much. We actually do have time for one additional question, so we'll ask one more, which is, there is sort of a recurrent theme that people hear from various outlets that DBS may adversely impact speech or adversely impact swallowing. Can you address your experience with that?
Sure. I've never heard of a swallowing issue. There are some reports that particularly what's called STN, which in other locations may make speech worse. And having done 800 to 900 and worked with very good neurologists, we're not that convinced, because the question really is it the Parkinson's or not? Now, one way to tell is to turn it off for a few minutes, and if your speech gets better, then it maybe is the DBS. And if so, it is possible you can program around it. So overall, it is possible that in some people, DBS in one particular target may make the speech a little worse, but it's not agreed upon by all patients. And it's a tough one, because people with Parkinson's already, many of them have speech issues, and how do you know? DBS doesn't help speech. Let's go that way. DBS doesn't help speech. So the question is, if your speech gets worse, but the rest of the symptoms don't, it's very likely that the DBS is helping the tremor, the rigidity, the bradykinesia, and not helping your speech. And that's why you think the DBS makes the speech worse. Again, I'm not going to say it can't happen in selected patients. So it's a very tough one. The only way to test would be to take identical twins with Parkinson's and do it. But again, turn the device off. We haven't seen that much, coming on 1,000 patients, probably maybe tens or so that we can really say it has some effect on.
Fantastic. So on that note, I think we're going to have to wrap up our question session. Thank you so much, Dr. Mogilner, for all that very, very good information. There is just a tremendous amount out there that people have to wrap their heads around. And thank you so much to our audience for asking those questions and trying to get a better grasp of what DBS can and cannot do. So I want to emphasize that today's program has been recorded. And so if you joined late or you missed part of it or you want to send it to someone else to watch or watch it again, the recording will be on our website within the next few weeks. So look for that on apdaparkinson.org. And so for any additional information, or if you have additional questions about deep brain stimulation or about something else, for additional resources, again, please visit our website at apdaparkinson.org for more information, or you can call us again at 1-800-223-2732. I want to mention now that our next episode of Dr. Gilbert Hosts will be on Wednesday, December 9th, 2020. That will also be at noon Eastern Standard Time like today. And on that session, we'll be hosting Dr. Chantal Branson for a conversation about Parkinson's disease and the African American community. So please join us for that. And now, if you enjoyed today's webinar, we hope you will consider supporting APDA with a donation, because with your help, APDA can deliver more programs and services like this one, which are needed now more than ever during these challenging times. And I want you also to remember to check out the APDA Symptom Tracker, which is an app that APDA has put together that helps you or your loved one track their symptoms with Parkinson's. And this symptom tracker is available for download on Apple Store or Google Play. So once again, I want to thank everyone for joining us today. We hope that you learned something, and I'm sure you learned a lot about DBS and all the new advances and how DBS may fit into your treatment plan. I want to thank again Dr. Mogilner for his incredible insight and expertise and sharing that with us today, which was really fantastic. Thanks so much for all your information. And please again, join us for the next session on December 9th, 2020, where we will be discussing Parkinson's disease and the African American community with Dr. Chantal Branson. And please visit our website, apdaparkinson.org, for more information and to register. Again, thanks everybody, and have a wonderful afternoon.